Thank you all for attending. My name is Kerry Randell and I will be chairing this symposium. Firstly, I would like to acknowledge all Aboriginal and Torres Strait Islander traditional owners of the country throughout Australia and recognise their connection to land, sea, culture and community. We pay our respect to their elders, past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander peoples. Thank you all for joining us for this symposium called Social Connection, Evidence-Based, Inclusive and Holistic Approach to Improving Wellbeing. I work for Bolton Clark, a large not-for-profit aged care provider in Australia, and we aim to support older people to flourish as they age. Our organisation has a research institute, and combating social isolation and loneliness is one of the key research pillars. Social isolation and loneliness have never been more prominent since the COVID-19 pandemic. And even before the pandemic, there were significant rates of loneliness reported. Researchers were highlighting the negative health and wellbeing impacts on community members of all ages. Social connection has been recognised as a way to protect people from the risk of loneliness, and the presenters in this symposium have been working with key stakeholders to develop strategies to support them to be better connected and improve their holistic wellbeing. This symposium starts with Dr. Michelle Lim and will lay the foundation of why we need to focus on social connection, outlining what loneliness is, its prevalence, implications, and what can be done about it. Professor Judy Lothian will follow, outlining the projects undertaken at a large national aged care provider in Australia, identifying that interventions to support wellbeing have a social component and that we need to go community-wide to have real impact. Dr. Bogdan Shiva-Jorka will talk about the work of the Global Alliance on Social Prescribing, what the building blocks of social prescribing are, and what good practice looks like in a community-wide approach to connect people, providing information on international perspectives. Then Dr. Raina Ogren will describe what has been done to date to apply those key elements that Bogdan talks about in a project called Connecting Communities to Care, based in one region in Melbourne, Australia. I'm delighted to introduce 4 very passionate speakers on this topic. Our first speaker, Dr. Michelle Lim, is the inaugural chairperson and scientific chair of Ending Loneliness Together, the leading national organisation focused on combating chronic loneliness in Australia. Dr. Lim is a research fellow at the Iverson Health Innovation Research Institute and Centre for Mental Health at Swinburne University of Technology. She is the director of the Social Health and Wellbeing Laboratory, which generates evidence-based research in loneliness. Her research involves understanding the drivers of loneliness over time and developing consumer relevant and effective digital interventions to reduce loneliness. Dr. Lim is also a practicing clinical psychologist. Thank you, Michelle. Over to you.
Welcome, everyone. I'm here to present the first of 4 presentations in this symposium, Social Connection, Evidence-Based, Inclusive and Holistic Approach to Improving Wellbeing. And this is in the World Congress of Gerontology and Geriatrics, the IAGG in 2022. So I'm here to do the first presentation, which is setting the scene, loneliness and well-being in older people. My name is Dr. Michelle Lim. I am the chair and scientific chair of Ending Loneliness Together. So for those of you who don't know, Ending Loneliness Together is a national not-for-profit organization in Australia that's actually leading the way to combat chronic loneliness over here. We do so by really developing the evidence base, building resources and tools, influencing government and raising public awareness about chronic loneliness. So this particular organization is underpinned by evidence, primarily because what we found was there's a gap between what we can see in science and what's being understood and done in practice. For those of you who want to know more, you can access the summary of evidence about loneliness across the lifespan in the Our Ending Loneliness Together white paper, and that's available on the website. I will really start by setting the scene to really define what we're talking about today, because some of these terms can be very confusing. The Global Initiative in Loneliness and Connection has just released some position statements and defined some of these concepts for us to really help us pin down what we're actually talking about. And the first definition I really want to kind of talk about is around social connection. It really reflects a human need for regular contact and interaction with a variety of different people, and the need for to have relationships that can be relied on to kind of meet different kinds of needs and goals. And hopefully these relationships are of high quality. So social connection in many ways refers to having less loneliness and also less social isolation, which is an objective indicator of having fewer people around you. But today we're going to be talking about loneliness. And loneliness is a subjective experience, and it's subjective, it's unpleasant, and it's distressing. And the feelings come about because you have a lack of connection from other people. And also alongside that, a desire for more and more satisfying social relationships. And this is really critical to remember. When you have a desire for more and more satisfying social relationships, that desire, not having those needs met, increases our stress and increases negative responses in our body and our mind. And this is probably why there's an increasing robust evidence in the scientific literature that talks about how loneliness shortens lives and leads to poorer health. We already know that people who are lonely are around 26% more likely to die earlier. People who are lonely also experience poorer physical health, including things like cardiometabolic disease. So we know from large epidemiological studies from the UK and Denmark that if you're lonely in the first year, you're really more likely to report higher incidence of poorer heart health and things like type 2 diabetes around 4 years down the track. Now, why this is the case and the mechanisms that drive it is still very unclear. But we do know as well that loneliness is often thought to lead to poorer mental health. Interestingly, in the scientific literature, loneliness is very much, the robust evidence around the physical health has actually been a lot more than the mental health, but we actually tend to speak about loneliness within the mental health space a lot more. So what we do know in longitudinal studies is that loneliness increases your severity of depression, social anxiety, and non-clinical paranoia. This is across the lifespan, including people who are around 90 years old. And depression, it seems to be the concept that's most studied. But what we have found in older adults, the work that's done by Professor Cassioppo and his team, is that loneliness increases depression, but depression does not necessarily increase loneliness within large cohorts of older adults aged 50 to 69. So unfortunately, we also know that if you are severely lonely, you're also more likely to report increased suicidality. And this is especially so in older men, which is a real worry. But more generally, what we have found in studies is that if you are lonely, you're about 17 times more likely to have made a suicide attempt in the past 12 months. And that's extremely, an extremely frustrating statistic, because what it actually tells us is that there's a point of prevention, that we can actually intervene and actually target loneliness for better mental health outcomes. But rather, the way that mental health services work right now, and much of their service delivery model is very much along the lines of tackling suicidality and depression and all the associated mental health symptoms first, before actually even considering examining the impact of loneliness on the person's life. And unsurprisingly, when you feel like you have a lack of connection with other people, you feel like your social needs are not being met, you're also not likely to take care of yourself. So we do know that people who are lonely also show very poor health regulation type behaviors, including things like moving a lot less, so being even though they can move, so actually having reduced physical activity, and also reporting kind of more poor quality sleep. So, taken together, we can see that lonely or people who are lonely experience more more ill health effects. And this is also true, particularly in older adults. So what do we see in that literature here, which is actually incredibly robust? And what I've done here, just for the sake of time, is really just pin down a couple of really important points that we see in the older adults literature. Now, very worryingly, we do see an increase in cognitive decline over time. So this is across longitudinal studies, and increased depression and suicidality, as I mentioned before, but also increased acceleration towards developing Alzheimer's disease. There's something about, again, loneliness and cognitive health and mental health that is increasingly having a huge impact in the older adults population. And unfortunately, we know that prevalence rates are amongst the highest as well in adults over the age of 75. And within international studies, that the percentage can range all the way up to 10 to 15% in older adults. In Australia, we have around 31.5% of Australian older adults aged 65 to 85 who report feeling lonely sometimes. So loneliness itself, I would say, is highly prevalent. But what we can see in the literature right now is that there's an increasing amount of investigations around what we determine as episodic loneliness versus chronic loneliness. And what we mean by episodic loneliness, for example, is transient periods under 12 months where most of us would feel lonely, but there's also a sub-portion of people who feel persistently lonely. And what we can see in the literature, including in older adults, is that people who have more chronic persistence of loneliness actually report poorer health outcomes. And again, this really speaks to us, a call really to think about loneliness as an antecedent to poorer health and well-being outcomes, and that there's a point of prevention and intervention before these health problems set in, that we can actually intervene in different ways. And I'm going to kind of talk about what can we do together right now. And I'm going to introduce you to this model. It's a conceptual model of loneliness, which was actually developed to account for the complexity of loneliness in people in the general population. So what we do know in the literature is that everyone's vulnerability to loneliness is actually led by different kinds of predictors. So we know that all of us in life will go through particular social transitions, and that's when we often have triggers that will actually lead to moments where we might feel lonely. But depending on how long we stay lonely for, it really is influenced by a number of things. So it includes things like our risk factors. So all of us have different kinds of risk factors ranging from demography. So your age is one, so older adults would be more predisposed in this case, to your health. So from your cognitive health, your physical health, your mental health, all the way down to your genetics, brain and biology factors, which an immense amount of work has been done in Europe around genetic and brain processes of people who are lonely. And then that also interacts with the environment in which we're embedded in. So if the environment that I'm embedded in is rich and surrounded by many social resources, and I'm able to access them, then those things also predispose us to particular levels of loneliness. So the risk factors interact, and depending on our access to different kinds of solutions, it can actually lead to us trying to manage a particular kind of severity of loneliness. So in terms of solutions, again, it is really, this particular model really assumes a socio-ecological framework that can really try to be more inclusive of what we seemingly think is a simple issue to resolve, but really is a very complex issue to resolve, because again, it's not a one-size-fits-all solution to tackle loneliness. So this particular model really kind of tries to account for the different kinds of interventions that can be delivered depending on the person's preferences and the access to different kinds of solutions. I'm going to move on to the next slide, which can kind of give us a little bit more detail. And this is really a model that I recommend when we want to kind of think about how we can combat loneliness in older adults. So as you can see right in the middle, the older adult has to be in the center of this of our considerations, and I often kind of advocate, using lived experience and to increase the consumer relevance of the things that we actually recommend or deliver to in terms of solutions to older adults. This obviously applies to everyone across the lifespan as well, but what might work for an older adult and in their circumstances is very different probably from what might work for a young person, for example, or someone who's in the workforce. So we really need to think about the consumer and the end user right in the middle and the center of our approach. And of course, we need to try to marry this with the scientific data, because that's really a rigorous way of thinking about how do we develop effective solutions that works, that doesn't cause harm, that actually is cost effective down the track. So evaluation and understanding risk factors, using kind of robust longitudinal type study designs and evaluations is really critical to key. And so for the older adults, really kind of obtaining number one, their knowledge, skills, attitudes, and behaviors for that stage of life. Obviously, we have to also account for the variations within the individuals. And again, within even each age group, it's not a one size fits all. Everyone's different and everyone has different accesses to different kinds of social resources and environments. We need to think about how their family and social networks can support them in actually combating loneliness. And if there's any kind of institutions around them, which is things like if they're still in the workforce or doing volunteer work, or if they are actually being supported by services, whether it's community aged care or residential aged care, or the health systems in which they function, or the community that they function in. And also just the general public, what actually, how do the general public actually see older adults who are lonely or who might be predisposed to lonely, and how can they help mitigate this chronic loneliness or intervene? And last really is around governments. And this is really speaking to whether it's a federal or state or local government, where we can actually change the policies in which we live, work, and play to actually try to support the facilitation of meaningful social connection, or in order to combat loneliness and social isolation. So an example would be the way we build our environment and the way we interact with older people. Do we actually have conducive environments in which we actually can come together to actually have more social opportunities to interact and to learn about our neighbors, for example, or perhaps are there policies and screenings at the health sectors or the community sectors in which we should be doing to make sure that we really capture older adults who might be experiencing transient loneliness and intervene before they actually experience kind of more chronic and persistent levels of loneliness. So there's a lot to think about, but this is the model and a comprehensive way of thinking about what we can do. And as you can see, there's many parts to this big picture. And what it also says is that all parts have to work together to really get the best outcomes for older people. And we all need to do a part in combating chronic loneliness in the older adults. And that is the end of my presentation, and over to the next speaker.
Thank you, Michelle. And now I would like to introduce Professor Judy Lothian. Judy is the Head of Research and Principal Research Fellow at Bolton Clark, formerly known as RSL Care and the Royal District Nursing Service. She is an adjunct professor in the Faculty of Health and Behavioural Sciences at the University of Queensland, Associate Professor in the School of Public Health and Preventative Medicine at Monash University, and in the Institute of Future Environments, Queensland University of Technology. Judy's research is underpinned by a 20-plus year career as an allied health clinician and health service manager. Her specific interest is the creation and implementation of health service research that is co-designed with end users to improve the quality and safety of health and social care for older people. Thank you, Judy.
Well, thanks, Michelle. Good morning, afternoon and evening. My name is Judy Lothian and I'm joining you from Melbourne, Australia. And I'm going to share some of the learnings about our experiences with social connection in aged and community care from 4 of our case studies. I would like to begin by acknowledging all Aboriginal and Torres Strait Islander traditional owners of country throughout Australia and recognise their connection to land, sea, culture and community. And I pay our respect to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples. I'm from Bolton Clark, and that's Australia's largest not-for-profit aged and community care provider. We're located in almost every state and territory, and we support people in later life in their homes, in retirement living communities, and in residential aged care. I have the privilege of leading the Bolton Clark Research Institute. In our research, we collaborate with all stakeholders, including our clients and families and frontline staff, to co-design our projects that either create or modify models of care prior to implementation and evaluation of effectiveness. And one of our key research priorities is combating loneliness and isolation through the development and testing of models of care that create and facilitate social connection. These are the 4 case studies that I'm going to talk about. The Older Women Living Alone project, where we co-created supports to optimise independence. The Peer Support for Older Women project, where we implemented some of those co-designed supports in a regional community. The Being Your Best program, which is an asset, community-based approach to reduce the impact of frailty. And How Are You, which provided volunteer peer support to reduce loneliness and depressive symptoms. The first project focused on older women living alone in metropolitan Melbourne. The 2 main aims of this project were to identify the social, health and economic disadvantages that impact the wellbeing and independence of older women living alone, and also to co-create strategies that would help them to be able to remain living independently in the community. It was a multi-component project which commenced with a systematic review. We analysed our home care data. We conducted interviews and co-design sessions, as well as a health economic evaluation. Now, for the co-design, we held the sessions with the older women and with the service providers separately. And this was quite important because we needed to ensure that the women felt comfortable in a peer-supported environment. We shared the findings from each group session, and then at the end, we brought the 2 groups together to synthesise and prioritise their collective thoughts. The co-design sessions identified 6 key barriers to accessing support that would help maintain independence. Although there were barriers around finance, transport, mobility, and mental health issues, alongside not having enough knowledge about what services would help them, social connection and participation were really seen as very important barriers. Now, the women and the service providers came up with 10 strategies, as you can see here. They then prioritised them with a health economist using multi-criteria decision analysis, which is a process that identifies and applies weights to the desired outcomes. Now, as you can see, All of these co-created strategies involve services that the women felt would help maintain their independence. Importantly, though, the women wanted each strategy to provide peer support and social connection because they felt that was the vital part that would help optimise their health and well-being and help them remain independent. The second study was POWER, and POWER set out to implement the top 3 strategies co-designed by Aula. Now, this was a 4-part study, and this was conducted on the outskirts of Melbourne. Now, because the first study identified a need for peer support and social connection, we first looked at the evidence around what the framework should be to comprise a peer support framework. We then looked at what services were in the region because we didn't want to duplicate anything. And then we looked at the area where we could implement the strategies. This again involved co-design with older women, potential peer support volunteers, and the service providers in that region. Now, the 3 strategies and services that had been prioritised by the first study involved exercise buddies that would support the older women to have peer support and motivation to keep active through exercise. They also thought about volunteer drivers to support them to attend appointments and go shopping, but to also have social connection over a cup of coffee or a bite to eat. And handy help was another strategy where they would like someone to come and do odd jobs like changing the light bulb or cleaning out the garage. But we realised the local council in the region offered this service, so we didn't progress that idea. But as you can see, the volunteer driver and the exercise buddy ideas all revolved around peer support and social connection beyond that task at hand. We then co-designed the peer support framework with everyone in the region, and then we co-designed the implementation and evaluation plan, and that was mainly around access, availability, acceptability, affordability, adequacy and awareness, and also what success would look like. Unfortunately, the pandemic struck, and with 2 years of recurrent lockdowns and restrictions on such activities, the project had to cease. But our service provider partner in the project, Uniting VicTas, is now looking at incorporating these ideas into their everyday practice. The third case study is a program that we co-designed with older people and professionals that would help identify and mitigate frailty. And this was the Being Your Best program. And we worked with 3 hospitals and our own Bolton Clark clients. Now, frailty affects 1 in 2 older adults, and it's a state of vulnerability, and it impacts our resilience and our physical, cognitive and social well-being. This is a 2-part project, and part 1 we finished just prior to the pandemic hitting in March 2020. And in that, we had co-designed an intervention framework. And we're currently testing that framework in part 2 for acceptability and feasibility. Now, in part 1, we did use co-design to explore what frailty meant to older people and to clinicians. And all participants, as you can see here, described frailty as being multifactorial. And this led to the development of the Being Your Best program, which comprises education, but also with linkage to existing community services. And again, the important thing was promoting social connection whilst addressing mobility, healthy eating, cognitive stimulation and emotional well-being. The final case study is How Are You? And How Are You is a volunteer, peer-delivered, telephone-based social support service. How Are You was piloted some years ago in hospital emergency departments, and we were able to show that we could effectively reduce loneliness and depressive symptoms purely by having some telephone calls. And these telephone calls on a weekly basis are not counselling or therapy, they're just a social support chit-chat. And the volunteers work with the participant towards transitioning them to connect over a 3-month period with local community supports. The program trains up the volunteers in telephone skills. We also developed a video, and that has information about identification of mental health issues and when to refer to someone on for specialist help. At Bolton Clark, we established a corporate volunteer program, and this involves our staff from the non-frontline areas of the organisation, from IT, from legal, finance, and HR. And as you can see here with these quotes from participants and volunteers and clinicians, everyone enjoys the program. And importantly, this all happened during a pandemic, but the feeling about the program reflected what happened in the hospital program where we piloted a few years ago. So How Are You highlights the importance of social connection for everyone's well-being. It was also cost effective, and we've now implemented it into business as usual across Bolton Clark and in the hospitals. In summary, all 4 case studies highlight the importance of social relationships and the need to link with local supports in the community to build on these relationships, and also to make sure we have mechanisms that enable older people to be part of the activated community. For more information, here are some of the publications on this work. And I would like to thank everyone who is involved in all of these projects, particularly those with lived experience, because they are truly vital to make change to our system. Thank you for listening, and I'm now going to hand over to Bogdan in the United Kingdom. Thank you.
Thank you so much, Judy. And now Dr. Bogdan Shiva-Jorka is currently working as a medical doctor within the London Social Thames Foundation School. He is development lead for the Global Social Prescribing Alliance and clinical champion lead at the National Academy for Social Prescribing, as well as a collaborator for the Harvard Global Health Institute. Bogdan has worked as part of the National Primary Care Team as a student voice for the UK National Healthcare System, Director of Primary Care. His work has influenced national and international healthcare policy and has driven key changes within the undergraduate medical school curriculum. Working with a team of over 5,000 medical students internationally, Bogdan is the founder of multiple large-scale projects, including the NHS England Social Prescribing Champion Scheme, International Social Prescribing Day, Talk Cancer, and Medifine Education, an organisation widening access to medical students globally. Thank you, Bogdan.
Good morning, good afternoon, and good evening from wherever you might be tuning in today. My name is Bogdan, and I'm a medical doctor by background, and I work as clinical champion lead and Global Social Prescribing Alliance development lead at the National Academy for Social Prescribing in England. Today, I have the pleasure of speaking to you about social prescribing, a subject very close to my heart, especially as a young healthcare professional. And although I'd like to start with the positive things, I think I want to take a step back and give you some of the less positive aspects of my daily job within the emergency department. Every single day, I see patients for about 10 minutes at a time. I patch them up, I stick a plaster, and I send them back to the local community to what made them sick in the first place. I prescribe pills, often causing side effects, and I don't fix the root of the problem. I only patch them up. I repair them. I use a fix shop, a repair shop mentality that we've developed over the years called the sick care model. And what I wanted to talk to you first time round is I want to remind us all about the WHO 1948 definition of health. A state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. That was 1948. Well, we're 2022 at the moment, and within the hospital environment, and not only within the UK, but across the world, we still deliver a biomedical predominant model of care. And that needs to change. And for us to shift those values and beliefs, we have to embrace a true biopsychosocial model, which we know that we've been advocating for a long time, but we've not really made the policy changes. Within the UK, we've had the pleasure of introducing social prescribing as part of the core policy and government universal offer for health and social care. Social prescribing can be seen as a policy model and can be seen as a concept. And I will start with the concept because it's easy to grasp. And within the UK, we've established a social prescribing link worker job who is an individual that works the same way as a pharmacist, as a nurse, as a physiotherapist, a doctor. They are attached to a general practice and primary care. Normally, they also have started working in secondary care, but they do something wonderful for patients. They do something that I would never have the opportunity to do as a doctor. When my hands are tied because of time, the social prescribing link workers provide patients with the most valuable resource of all. They provide them with time. They listen to them, and they dig deep at the root cause of the problem. Social prescribing link workers map out problems together with the individual, and for those 1/5 of the people who would come to the hospital environment for pure social reasons, they are able to provide a menu of activities, a menu of support within the local voluntary sector to ensure these individuals are supported to prevent disease and to also create health as we age, to ensure we don't take just a reactive approach to health and care as we've taken for so many years. In terms of the policy model within the UK, there's a fantastic paper that you can read online looking at the ways in which we've seen and examined social prescribing, the benefits in terms of health inequalities, and that is particularly useful in light of COVID-19. We know telling people and signposting doesn't work. We know just telling someone what to do doesn't work, especially in light of health inequalities, because some individuals have been less fortunate to be born in a different environment or not have access to education or resources. And for those individuals, the social prescriber link worker does the extra hand holding. Some of the individuals we see may just require signposting and a light touch approach. But for those with health inequalities, we know the social prescriber link worker will assist and will go to those voluntary activities that can be found within the local community, or will allow them to apply for benefits, or pair them up with other individuals to combat loneliness, and so on and so forth. And so the social prescriber link worker model and the policy model in the UK has been crucial to this. And since 2019, when the NHS long-term plan was launched, which is the roadmap for the next 10 years in the NHS, was committing to supporting over 900 people to benefit by 2023 and 2024 from social prescribing and personalized care. And the promise was that by 2024, we'll have up to 4,500 link workers working to support patients in social prescribing. We know at the moment we have approximately 2,800 link workers working in primary care in the UK, and that's growing at the moment. We know it's very important to develop a wider ecosystem. We know it's important to work together with local communities, and social prescribing does exactly that. In Frome in England, there's been a fascinating model put together whereby the local individuals in the community, so firefighters, police members, hairdressers, taxi drivers, have been trained to know how to spot the effects of mental health problems, to spot financial problems and financial burdens and or loneliness within the local citizens, and to support them by referring them to social prescribing. The referral in the UK is mostly done by healthcare professionals who spot those psychosocial needs in the individuals. However, more prevalent is becoming self-referral, but also involvement from general practice receptionists, discharge coordinators in secondary care, and several other avenues, so not just clinician-based as well. And this is just to echo that health does not start within the hospitals. It doesn't start with emergency doctors like myself. Health starts within our local communities. It starts with us, and it starts with individuals who are able to support each other and to work with social prescriber link workers, and to not just seek health support from medical experts like we've done for so many years using a sick care model, especially in light of health inequalities. And this is truly an international movement that spanned across the world, and they are called differently across the world. Social prescribers in many places, they are community connectors in Canada, they might be ASHA workers in India. Many of you may know they are social workers in India. Shikatsu Shien in Japan, well-being coach in the Netherlands. But it's worth noting that the role is very different from a country to another. The UK established a job. The social prescriber link worker is a new job that was created within the healthcare system. But across the world, there's different models whereby social workers have taken the job of the social prescriber with extra education, extra payment, and extra support to make sure they are able to deliver that job themselves. And there's beautiful examples of inter and cross-sectoral collaborations from across the world. One such example is the newly established Canadian Institute of Social Prescribing, together in partnership with the Canadian Red Cross, which acts similarly to the National Academy of Social Prescribing in the UK to support the government in Canada to implement social prescribing in the longer term. In the UK, we've established the Social Prescribing Champion Program because we know the frontliners, those on the ground who will deliver care, are the ones that need to know and need to shift their mindset and values and beliefs to advocate for a true biopsychosocial way of delivering care. And so we put together a yearly cohort of 200 plus individuals, from receptionists to discharge coordinators to physiotherapists and occupational therapists, to all the way to consultants who work together to shift those values and beliefs, and they act as champions within their workplace. They learn about social prescribing, then they teach others, and then they reflect on what they learn, and they cause change locally within their place. And when we ask what does it actually mean to be a champion, they simply say starting a conversation over coffee about the benefits of social prescribing with colleagues, or acting as a friendly face for those who have social needs within the healthcare environment, and referring them to the link worker in the UK. In terms of future workforce, we've worked to support the future generation, the incoming doctors and incoming healthcare professionals across the world. We've reached 20,000 students in the UK and young doctors who are teaching social prescribing themselves, and is now it's been made part of the core curricula in medical schools across the UK. We have a summer internship with Harvard students, and we've also launched a framework for countries from around the world to launch their own schemes to train and support students and healthcare professionals to deliver a true biopsychosocial model of care. In terms of the Global Social Prescribing Alliance, this is a true collaborative effort of individuals from all over the globe. We have global bodies who founded the Global Social Prescribing Alliance with support from World Health Innovation Summit, WHO, and United Nations Global Sustainability Index, as well as the Global Social Prescribing Network of international partners with representatives from all over the world. The aim was simple, to bring together people who want to share their own social prescribing models from across the world, learn from each other, and establish some publications that will guide others from countries where social prescribing has not yet become universal. And there's a playbook that we've developed for good social prescribing, which you can find online as well. And this is just a picture to showcase a true global network of individuals who are acting as representatives and who are sharing their knowledge and exchanging what they've learned with each other. For those of you evidence fans out there, do join the Social Prescribing Evidence Evidence Collaborative, put together by 8 leading universities in the UK, where you can find out more about the benefits of social prescribing. And there's interim reports with evidence from the UK to show that social prescribing is estimated to save up to 6 million primary care appointments each year, which relieves pressure on the GPs and, of course, provides a huge return on investment. And you can read further following that link as well. Some further reading for you all as we draw to an end, and I would love to hear more questions from you all. We hope this is a revolutionary model that is also old as the hills, because many of you might have done this in the past, but it's a way of consolidating this into a formal policy model that we can share with countries from around the world. You have the playbook that you can read online, the student framework for anyone who's interested in teaching the future healthcare professionals of tomorrow. We've published a paper in BMJ Global on global developments that you can find out, and a really good resource from our colleagues from WHO, a toolkit on how to implement social prescribing that you can find online. For anyone interested in learning visits, do give us a shout. We love learning from each other. We're conscious the social prescribing model in the UK is not the best. We want to learn from you too. And so do get in touch if you'd like to book a learning visit from us as well. It's a pleasure meeting you all, and I look forward to your questions. And thank you very much for having us. And I hope you enjoy the presentations from my colleagues in Australia and the great initiatives led by Bolton Clark and the Campaign to End Loneliness in Australia as well. Thank you very much.
Thanks so much, Bogdan. And now Dr. Raina Ogren. Working as a clinical podiatrist, Raina recognised the limited evidence being implemented in practice in health. This led her to complete a PhD and postdoctoral studies in the area of providing best practice care in people with diabetes and older people with wounds. Her research has naturally evolved into developing services and education resources that have been co-designed with community members to improve health outcomes for older people, translating evidence into practice. Her goal is to support delivering evidence-based practice reform in models of care that make measurable change to community members and health professionals' lives. Thank you, Raina.
Hello. I'd like to thank the organisers for giving us the opportunity to present to you all today. I want to talk about how we have applied social connection principles in practice in our community-wide social connection approach, connecting communities to care. And please don't forget to tweet. My Twitter handle is posted throughout the slides. So Connecting Communities to Care is a study modelled on the proven success of social prescribing programs, specifically drawing from Health Connections Mendip UK, where we had the opportunity to visit and view what they were doing and how they went about it. In addition to that, we've been working for a number of years on interventions to support older community members to be as well as they can. And a community-wide social connection approach, Connecting Communities to Care, is the culmination of all of this. So this is a 4-year pragmatic mixed methods perspective study, and we're in the first year, working with stakeholders to co-design and then implement and evaluate this social connection approach that uses social prescribing as a key element. It's focusing on older community members, specifically in one local government area of metropolitan Melbourne called Glen Ira. The aim is to reduce loneliness, social isolation and depressive symptoms and optimise holistic wellbeing, taking the World Health Organisation's definition of physical, psychological and social wellbeing. So social prescribing, as Bogdan described and as defined by the National Alliance of Social Prescribing, is bigger than just prescribing someone a social activity. They define it as supporting people by paid connector roles to make community connections and discover new opportunities, building on individual strengths and preferences to improve health and wellbeing. And social prescribing has 4 components. First, the individual who will be having the prescription. Second, the referrer. Third, the connector role. And fourth, then the activities that will be referred to. And it's a pathway of relationships to link people to a set of activities for their health and wellbeing. And we're wanting social prescribing to form a key part of our Connecting Communities to Care program, but it's not all of it, because we want a whole of community approach. And taking the very beautiful words developed by the Social Care Future Movement Group in the UK, we all want a good life. We want to live in a place we call home, with the people and things we love, in communities where we look out for one another, doing what matters to us. And we know that this isn't a pipe dream that we're striving for, as it's been done before in Health Connections Mendip in the UK, who achieved something like this. So this leads into our project, Connecting Communities to Care, funded by the Ian Potter Foundation, Perpetual's Impact Philanthropy Grant Program on behalf of the Ian Rollo Curry Estate Foundation and the Felton Bequest, managed by Equity Trustees. And our team consists of, from Bolton Clark, myself as the project lead, Kerry Rendell as the project manager, Professor Judy Lothian, Head of Research, and Research Officer Elizabeth Robinson. And from Alfred Health, Dr. Daniel Feinberg, General Medicine Consultant, Kayleen Fiddis, the Manager of the Australian Disease Management Association, and Angela Yerolamu, the Service Development Manager from the Southeastern Melbourne Primary Health Network. Now, connecting communities to care aims to build on what we know of existing programs and evidence so that we can develop something that learns from what others have done, and with collation of information to identify the core components to enable this to work. Again, built on that Health Connections Mendip model as the foundation. And then working with local people and service providers in co-design to shape the program to suit our local context, then implement and evaluate. Now, co-design entails the active engagement of all stakeholders, drawing on their unique experiences to shape the design of tools, products or programs. And our research institute at Bolton Club has adapted a number of approaches for co-design and have found that this works for us. And while it looks a linear approach, we know it isn't, but it does flow along a forward trajectory. It involves starting with discovering, so building relationships, sharing experiences, gathering insights, goals, information, including looking at the literature, and then synthesising these findings to identify key areas to address, then turning those ideas into improvements and finally acting on those ideas. And today we're talking about the first few steps because we're yet to get to that delivering. So the research we've done in supporting older community members to optimise wellbeing in the past has made us look at what's already out there in the community-wide connections, and that's where we found that the UK had developed that Health Connections Mendip, and that involves multiple aspects for a community-wide approach, including raising knowledge and awareness of existing supports in the community, building networks and connections between community members to help each other, and then having paid roles to support those who need help to link with these supports, and they are the trusted providers, and then engaging local general practitioner physicians and other healthcare providers to formally prescribe social activities, be that trusted link to social supports, linking the medical and social care. And in the UK, this has all led to reduced unplanned hospital admissions. So using this as a foundation, we reviewed the literature in each of the components identified by the Health Connections Mendip approach. We extracted data on the barriers, enablers and outcomes for each component, and then subgrouped the findings into themes and identified enactables, which mean what works and can be applied into practice, as well as identifying what areas need to be worked on with local stakeholders in co-design. So the 8 core components were verified from the literature review, which were the access aspect, community assets, which require a service directory outlining all the local supports in the area, the paid connector role, and the actual intervention component, and social capital, which is that value that can be gained by connections between people in the community, as well as the feedback and evaluation, so the sharing of information to keep up engagement of all stakeholders, with volunteers to support people to be engaged and funding to ensure sustainability. But how does this look on the ground? Well, in simple terms, we need to raise awareness about the program, that it exists and what it is, having a community members to reach out and connect, and developing rapport and finding out what matters to them, developing goals and planning to be able to achieve them, and then linking to the support and making sure it's made a positive difference, following up an evaluation, which looks nice and simple. However, this is a lot of that back-end work that's needed to consider to enable the service to work, which means we need to know that someone who has social care needs, they need to perceive they have a need, and the service needs to be approachable. They need the ability to seek the program, but that program needs to be acceptable to them, so they want to take part in it. They need the ability to reach it, so it needs to be available and be able to accommodate them. They need to have the ability to pay for it, so it needs to be affordable, and they need to have the ability to engage. It needs to be appropriate for them. So we need to ensure that all of these things happen, hence co-design. And that means we need to work with those who will be involved in this program. And so last year, we sent out a call to action, asking local older community members for their help to build a network to connect in their area. And the message was shaped with our community partnership group at Bolton Clark. And we asked our networks to share widely. Due to COVID, we started with those who were able to engage online with a view to having face-to-face engagement once restrictions ease. So coordinating co-design is always an exciting adventure, and we managed to get 3 people online at one time, 3 local women. And we first wanted to make sure that the concept of having someone linking people to local supports was valid and what they thought would be needed. Using a persona, which was a fictional person who embodied characteristics that were common, because we know that people find it easier to talk about others rather than themselves. So Jan's story was about a recently widowed person who wanted to stay in her own home and keep independent, but was struggling. So the group brought up that multiple supports were needed and an approach that enabled Jan to link to local supports with some sort of connector role, and they felt that that would be incredibly helpful, which confirmed the approach that we had proposed. A second session was held, which was a hybrid approach, 2 of us in the office and 4 online, and we brought in the awareness piece. How can we engage people in a way that's welcoming and would increase the likelihood of engagement? We showed examples of other messaging and asked their thoughts on what would work for them. And we also asked their input on selecting a logo. We used an online logo tournament to generate ideas and shared shortlisted concepts with them, shown here. So the group identified that the message needed to be framed positively, not too much information, and that people needed to know that any information that they shared would be kept confidential. They also identified the logo that they preferred. So session 3 was face-to-face with 5 older community members and was around exploring the user experience, the touch points into the program. And we used another persona, Beth, again to facilitate discussion and get them talk about someone else. So we started with the process of how people call in, and basically the group shared that we need to let people talk and encourage them to share information about themselves through providing short, practical information about what the program could do for them. We need to take time to build trust and rapport, especially in the early stages of engagement. A lot of people have been scanned, so building that trust was incredibly important. We also need to be able to meet when the person is ready in a neutral place like a cafe or a local library where further discussions about what would work for them could be had. Now, the session 4 was a hybrid session with 5 community members, and we went through how to make the message encouraging and how to make information that will be shared inviting. And we used mock-ups that were reviewed by the group of messages that we were interested in sharing. And you can see that the input of the group on the slide. We also worked through how to engage with older people to find out what matters to them so that we can plan what local supports would help them do what matters, which meant ensuring that the focus was on the person and making sure that the connector really listened and focused on what was a priority for them and not be patronising, which was really important. So we're now building further with older community members and service providers to shape the service linking aspects to social supports, develop the service structure, shape the website and the service directory. So thank you very much for your time. I've left our email for you to contact us if you wish for more information.
Okay, thanks so much, Raina. And now we have an opportunity to answer questions. So please feel free to post your questions in the chat function.
And thank you, Raina. It's so exciting to hear about, what's happening around the globe with social prescribing and social connection, and to be on that journey here in Australia, and hopefully to get to that stage where the UK are. Now, if anyone has any questions, please do post them in the chat. Okay, here we go. Bogdan, I think this one might be for you. The UK has a Minister of Loneliness, apparently. And so how has this made a difference to getting social prescribing becoming part of care delivery in the UK? And do you think if Australia or other countries had something like this role, it would accelerate the drive of the change at the policy level?
Thank you very much, Kerry, and thank you to everyone on the panel. I hope people enjoyed that presentation. I hope we get more questions in the chat. Do tweet at us and do use the chat as well. But going back to your question, Kerry, I think very much so a big difference, because it shows the support that is there across, not only across the implementation of it at the healthcare sector, but also the recognition within the government too. I think for us, it really consolidated the desire of formalizing loneliness. You know that loneliness counts or does damage to your health as much as 15 cigarettes per day, but you don't see billboards with loneliness as much as you see billboards with cigarettes. So I think having a minister for loneliness really consolidated that belief and understanding that loneliness kills. Loneliness is an emerging issue and a big issue for all of us. And I think specifically it helped us get that recognition from policymakers and get a government spokesperson who would advocate for it as well. I think it really formalized the movement, and it allowed us to have a more united, louder voice. And I think with your support and with support from colleagues from across the world, we're hoping to perpetuate that voice even further and have that loud voice echoing across the world. So for anyone listening, do join it's a true revolution, I would say, in terms of health delivery, and a transformation in the ways in which we've been practicing medicine that needs to change once and for all.
Thanks, Bogdan. And I know, Michelle, you're at the forefront of driving that policy change here in Australia. Can you let us know how big an issue loneliness is around the world?
Well, we know that before the pandemic, Kerry, 1 in 4 Australians reported problematic levels of loneliness. And the recent kind of global meta-analyses have actually showed that loneliness has increased, and it's also an issue that goes across borders. So it's not an issue that's constrained to just developed countries, but also low and middle income countries. And this is why the World Health Organization is really kind of focusing on actually addressing loneliness and social isolation around the world, and really kind of pushing for global advocacy. So we recognize that there's a lot of really great solutions out there, but until there's really kind of real policy changes or kind of more systemic frameworks that we can kind of work from, not much is going to change. We all do a little bit, but really I think it's that systemic change that's really needed to drive home, I guess, better solutions and also wider implementations of good solutions. Absolutely. Thanks, Michelle. And Bogdan, actually another one for you, if you don't mind. What we're hearing in Australia, and one of the biggest challenges is getting that clinician buy-in. So do you have any tips and hints for us? And I know eventually that self-referral is, you've reached that stage in the UK, which is very exciting, but for us here in Australia, we're still at the very early stages. So if any tips on getting the clinician buy-in for us, I think would be great.
I'll keep that very short, because I think it's one of the most important aspects is sometimes designing the future for the future healthcare professionals, but we often design it for them, not with them. And I think what's happened over the past few years is we've advocated for a model in which we place ourselves in experts that sit within the hospitals that tell people what to do, and we're running out of resources slowly, running out of staff, and with doubling the amount of people living over the age of 60 by 2050, I think it's becoming impossible to do that. And I think I would start one generation at a time. It won't be a quick fix. I would say the long-term change that could really happen by training and educating the future workforce of tomorrow. And even if it takes us 5 or 6 years and now to do that, I think it's a big win in 5 or 6 years' time when you have a new generation of healthcare professionals coming through the door, one that really supports and advocates for social support within the local community. So personally, my top take would be training. I would say there's a famous quote, I hope it's Aristotle and I'm not embarrassing myself, but it says, give me a man until there are 7, give me a child until there are 7 and I will tell you the man eventually. So I would say train them whilst they're young is my top takeaway from there.
Perfect. Wonderful advice. Well, I think we have run out of time. So I want to thank our amazing, passionate speakers for your presentations today, Michelle, Raina, Judy and Bogdan. And thank you to the audience for joining us from wherever you are across the globe. Thank you.